We're just letting a few people in and we'll get going here in just 1 second. Good evening, everyone, and welcome to the Myasthenia Gravis Association's virtual monthly meetup. We're so glad that you're here. If you're joining us for the first time, we hope that you'll spend time navigating our website and getting to know us. Additionally, if you need a new patient packet, please drop us an email at info@mgassociation.org. I'm Allison Foss, and this evening I'm joined by Katarina Eads, our outreach specialist. We also have the privilege this evening of hearing from Dr. Tania Papsdorf. Dr. Papsdorf leads our MG Clinic partnership at Lake Regional at Lake of the Ozarks. As a reminder, this evening's topic is myasthenia gravis and women's health. If this doesn't apply to you, you may want to log off the webinar and join us for a different one. While Dr. Papsdorf will be answering questions at the end, she will not be addressing specific medical situations. For those, we encourage you to speak to your care team. Following the presentation today, we'll be sending out a survey, and we would love your feedback. Dr. Papsdorf, we're so glad that you've taken the time to join us this evening. Thank you so much for being here. I'm going to let you take it away.
Thank you. Thanks for having me. I am really excited to talk about tonight's topic, and I appreciate Allison and the team for asking me to do this. So that's I always learn things when I talk, and I think that that's important too, to always keep learning and look up the latest stuff. And so it's very fun. There's a study that just got published last month, and so in neurology, and so that was kind of awesome timing. So welcome everybody, and let's, I guess, try to get started. Bear with me, like I told Allison. I am not always the the best at this, and so I'm gonna do it. Let's see. So we should be pulling this up. Okay. So like she said, we're going to talk about women's health and myasthenia gravis, and I'll take questions at the end, and be sure to write them down, and we'll go from there. I do not have any disclosures related to the topic we are discussing today. So like I said, when I started looking at stuff for this talk, the thing I think that just really stuck out to me is the lack of really large studies about women and myasthenia gravis. And I was struck by it because anymore, there are so many studies on myasthenia gravis, endless studies, really, especially about treatment and just all sorts of things. It's very exciting, but when you look down into the nitty-gritty of women and myasthenia, there is, I would say, a poverty of research, and of good quality research. It's not just any research. It's research that has large studies that we can rely on. So that is a problem in medicine in general. We know that, the amount of research that gets spent on women's studies, the inclusion of women in a lot of studies, that's lower than it should be. And we always talk about it, but I think it's good to remind ourselves, just because I think for government purposes, we should be talking to our senators, we should be talking to those people that provide money to the government, because these topics are important, and they're important because excuse me, I'm getting over a cold. They're important because we tell people what to, you know, we give advice to people, we counsel women, and if we don't have the studies to back us up, we kind of are left in a little bit of a hole. And not just us, but you as the patient, you know, you're not able to know what to do if we don't have that information. Okay, so I'm done with my spiel on women and medicine and the amount of research. So, as we know, with autoimmune diseases, myasthenia gravis affects women more than men. And this is about 2.5 times more, especially during the ages of 15 to 64. So we see this increased effect on women during the what we call early onset MG, and that's ages 19 to 50. And in that age range, we see a 3-to-1 female to male ratio. So for every 3 women that get diagnosed, there's 1 man. So that's something that we see commonly in autoimmune diseases, but definitely very stark in myasthenia gravis. So we also see that women tend to have more thymic hyperplasia, so overgrowth of that thymus tissue that we think is implicated in myasthenia gravis. And we also see that they have acetylcholine antibodies more frequently than men. Musk antibody positivity is also higher in women with myasthenia gravis and also higher in African Americans. So this is an old slide from Dr. Howard, my mentor. He always used to show us this, and it's old, but it's still pretty. It still applies. This is 984 patients in the clinic at the University of North Carolina. And you can see the prevalence of females or women in blue over the decades. So first decade, second decade, so forth. And we see this prevalence really going up during the reproductive years and coming down as women age. And then you see the opposite with men, right? Men, which is what we know, men tend to get myasthenia gravis more frequently later in life. Women tend to get it earlier. So why is it? Why is it that women get it earlier? So we think that it's because estrogen causes a reduction in the expression of a gene called the autoimmune regulator gene in the thymus. I went down a rabbit hole with this because we've known about this gene for quite a while, but we know so much more now about what it does. So if estrogen, which is, of course, we have higher estrogen when we're younger as women, lets a break off of this gene. It's an autoimmune regulator, so generally something that would protect us from autoimmune disease. Then we see this increase in the immune system autoactivity. So we start making antibodies against ourselves. And so it's a very interesting gene because it's affected by the amount of estrogen. This autoimmune regulator gene is actually not just implicated in myasthenia gravis. We see it in neuromyelitis optica, type 1 diabetes pathology, Sjogren's syndrome, and even food allergies. So this paper that I reviewed was really amazing. Just like I said, I went through a rabbit hole learning about it a little more and all the new stuff that's come out about it. So it's a really important gene. And I guess what stinks for us is that it's affected by estrogen levels. So the gene is in the thymus. Well, it works in the thymus gland by transcribing. So the genetic material that we have in each of our cells sends. Trying to see how to explain it in a good way. These thymus cells have DNA in them. That DNA has this autoimmune regulator gene, which actually transcribes information or gives information to the rest of our immune system. You know, attack this, don't attack that. I'm simplifying it greatly, but I'm trying to make it something that we can all understand. And if that develops normally, you know, you're not going to attack yourself. If there's a deficiency or something goes awry in that gene, then we have autoimmunity, which is not good. That's how you get autoimmune disease. So we know that there are differences in clinical outcomes in women with myasthenia gravis. Women tend to experience less clinical improvement than men, both in self-reported, meaning those things that your doctor hopefully makes you fill out at clinic visits, seeing how good your myasthenia or how bad it is. So we see that women tend to express that they're doing worse than men, but also in clinical measures. So actually testing the strength, measuring all sorts of clinical measures in women, we see that difference show up. There was a study in Denmark where they noticed these differences by looking at all the um, scales, the MG-ADL, the QMG, the QOL. And between men and women, even when you're looking, if you're adjusting for the time they've had the disease, how old they are, how bad their myasthenia is, and thymectomy, if they had a thymectomy or not, there was still that difference between men and women. So women also have an increased incidence of refractory disease. So this is the uh, refractory disease, meaning that it does not respond to the typical myasthenia gravis medications. And so we see that higher in women than in men. We also see that it's longer to diagnose women. And this, of course, probably has a lot of implications diagnosing women because your primary care or whoever your first touch person is when you're telling them about your symptoms might just think, oh, you're tired, you're a whiny woman, you're not getting enough sleep, maybe too stressed, taking too much care of too many people, which may be true. And a lot of us women definitely have that, but it also prevents us from getting diagnosed, quicker than men. And then women tend to present with generalized symptoms more often at the beginning of the disease. Some good news, I don't want to make you think all is bad or the world is ending. The good news is that women tend to have remission more often than men after thymectomy. So once you get your thymus gland out, then women tend to do better than men with that. And I think the reason, part of the reason, as I was looking through the different studies, there were a lot of studies looking at this, was that women tend to be younger when they get thymectomy. And it's that kind of age group where they're a little bit healthier than being older. So the exciting part, right, about women's health, hormones. There is so much about hormones out there as I was reviewing a lot of bad information, a lot of information apparently on social media. I'm not on social media, so I don't know, but I know that this is kind of just a hot topic in general, which is good in a sense, right? We're learning more about women and our changes in hormones through our lives, estrogen levels, of course, increasing and then dropping as we age. And then we also have all of these changes during when we still have a menstrual cycle. So the estrogen levels really increase during portions of the cycle and then really drop. So both estrogen and progesterone tend to do this. And I apologize. The reason it's important is because women tend to have symptoms either before or after these great drops. And so how that's related to autoimmune disease and specifically myasthenia gravis is very fascinating. So, as I said, surprisingly, and that's of course facetious, I'm not surprised. There are not a lot of randomized high volume studies to address the effect of menstruation. Menstruation, of course, being that fall of estrogen and progesterone. You see those falls after the high on MG in a definite matter. There are a lot of case reports, there are a lot of small studies, anecdotal reports, but no high volume randomized control studies. And the reason why this is important, I think it's good to point out, right? One study does not equal the Bible. So just because there's one study that says something doesn't mean that we can just say, okay, that's the final word on this. As clinicians, as researchers, as people who are trying to treat our patients based on the science that's there, we like to have the high quality studies, meaning you get a lot of patients, as much as you can in a study. You want to randomize them. Some of them go into get the drug or not, and then making sure that you're comparing those. And if that doesn't mean that you don't get good studies from case reports or small studies, but it makes it less likely that you have errors, less likely that you're not able to generalize those results. And so that's why we like to have the high level studies, so that we can more confidently tell our patients, yes, this is definitely true, or no, this is definitely not true. So when I talk about these studies, honestly, most of them are very like one study, two studies. Some of them are really old. You can see this one, 1977. So there's not a lot there, which was very surprising to me. So this one study that they tend to cite all the time, this one with that looked at, let's see, let me tell you, from 19, no, sorry, I want to make sure I don't tell you wrong. This was the exacerbation of myasthenia gravis one from 1998. They had 120 women who they asked about their MG symptoms and whether it worsened before, during, or after their period. 2/3 of women, or 67%, reported that they had worsening of their MG symptoms prior to menstruation. So 2 or 3 days before their period, their symptoms seem to get worse. So it's interesting, but again, it's one study, 120 women, not highly powered. There are reports that giving women birth control with the continuous suppression of ovulation, so not having an off week, does help. And some of these studies, little reports go back to as far as 1960s. So that's not a new thing, but just kind of stabilizing our hormones. The hormones for MG women seems to make a difference. Again, I wish we had more on this. There really wasn't a lot there. Most of what I found, like I said, were just small reports. Okay, I will spend a large part on pregnancy and postpartum, and that's mostly because that's what there is the most on with relating to women's health, because that's what we have studied the most, pregnancy and postpartum. And even then, with that, there are not a lot of studies, but it's good to see that there are more and more coming along. As I said, last month, there was one published recently from a pretty good sized study. I remember even as far back as when I was training in fellowship, Dr. Howard, my um, mentor, talked about wanting to do a study, and how there wasn't enough studies, and we had so many patients that he had treated that were pregnant, had been pregnant, and he really wanted to get that out. And I wish I would have taken a little more initiative. We did some other studies instead, but I wish at that point I would have taken a little more initiative to do that, because there really aren't that many studies. So maybe something to look into. So the issues in pregnancy, of course, are important because men, like we talked about, many women are diagnosed during those reproductive years. And obviously, if you're diagnosed with myasthenia gravis and you're thinking about having kids, you're also trying to think about what medications to take or not take. And that makes a big difference. One study reported that up to 38% of women said that they had decided not to have children as a result of their myasthenia gravis. And then another study said that fear of having a myasthenia gravis exacerbation during pregnancy was the most cited reason for women, and about 70% of those. So this is significant. You know, if women are making these decisions, we need to provide them with good information. Maybe they don't need to be as worried, or maybe they do, or maybe more informed about what the risks are. So animal models have shown that worsening in myasthenia gravis in pregnancy and the postpartum period, so after birth, could be due again to estrogen. Estrogen keeps coming up. So estrogen tends to increase the amount of cytokine production. So this is inflammation that is in our immune system. Cytokines and immunoglobulins, it's like your immune system gets ramped up. And we see this in animal models of myasthenia gravis. So we think that that's one reason why we see a worsening. Another proposed look is that this worsening, especially that we know in the postpartum period in myasthenia gravis, is because when you're pregnant, you have a lot of a protein called alpha fetoprotein. And alpha fetoprotein is a protein that the fetus is producing. It's primarily by the liver of the fetus and the yolk sac, and it helps with growth and lots of other things in the baby. But you get some of that in your blood. You're exchanging some of that with the baby, with the fetus. And alpha fetoprotein is really interesting because it seems to inhibit the binding of acetylcholine antibodies. So those antibodies in myasthenia gravis that you're making against yourself, it prevents them from binding to those receptors that cause weakness. So very interesting and very cool method by how we get protected during pregnancy if you have myasthenia gravis. But then the problem is once you have the baby, afterwards you get this drop in the alpha fetoprotein, and that's when we see worsening. So we see people getting better and even way better in the third trimester when they're pregnant because those alpha fetoprotein levels are high, and then worsening after those levels drop. So I looked up to see if there were any studies looking at alpha fetoprotein as a treatment, since we know it works so well in pregnancy. And there's not really a lot in for myasthenia in terms of the clinical trials of that. So very interesting. All right. So, like I said, going to talk about that study that just came out last month called The Risk of Myasthenia Gravis Exacerbation During Pregnancy and Postpartum. This was in Sweden. And, you know, when I was looking through all these studies, most of these like bigger studies are usually in Sweden, Norway, Denmark, and I think the reason that they're able to do these bigger studies, I'm sure there are a lot of reasons, but one of the reasons is because of their nationalized health cares. They're able to have registries. They have these national registries so that they say, okay, we have this number of pregnant women. These pregnant women have myasthenia. They're able to pull that stuff because of their nationalized system. The other reason it's probably a little bit easier to do studies in these European countries is because they have a more homogenous population. All the women are, generally white women, and they're all, similar. And so it's easier to do a good quality study that way. Harder here in the US when we have so many different factors and stuff, it wouldn't be impossible, but I think it's just a matter of just their ease of being able to access some of these registries that they get. So in this study, 112 women with myasthenia gravis were um, placed in the studies, and they had a total of 176 pregnancies. So some of these women obviously had more than one baby, and so that's why we have more pregnancies than women. And what they were looking at is hospital admissions with myasthenia gravis during pregnancy and in the year after, postpartum year, to the year before they were pregnant. So they wanted to see at the differences in hospitalization in these women. So we don't actually know if being pregnant itself increases the risk of an exacerbation. When we look at the literature, there's a lot of differences. Some literature says that you remain stable or even improve, which we actually see that in a lot of autoimmune diseases, MS, rheumatoid arthritis. Women tend to actually stabilize and not get worse many times during pregnancy. And then there are the reports of higher exacerbation rates, and definitely in the postpartum period, I think that's the highest quality of studies that we definitely have more information about after the baby's born, that postpartum period. So again, we come to that problem of a lot of these are small sample sizes, they're small retrospective studies, you're looking back, and then inconsistent definitions of what it means to have an exacerbation. So in the past, we, didn't always necessarily do the MGADL and have good quality studies to decide, how what it means to have an exacerbation. So the paper says, we know that this gap in knowledge makes it difficult to counsel patients, and it could be causing unnecessary anxiety. And maybe people aren't getting pregnant because they are worried about these things. So these women, I'm not going to spend a ton of time on their characteristics, the less fun part of studies, but I'll go through a little bit here. The median age was 30. Most of the women's, the median disease duration was 8 years. The severity of their MG tended to be a little bit on their lower side. So the MGFA, Myasthenia Gravis Foundation Association class, these are different classifications of the severity of MG. They tended to be, highly up here in the lower. They were doing well with their myasthenia compared to down here. They're doing a little worse. Nobody was in these lower classes. Most of them had thymectomy, so almost 74% of women had their thymus removed before delivery. So I think that would clearly affect the outcome. So if we did this in the US, I think it would definitely look different, perhaps. And then here, most of them had acetylcholine antibodies. Hyperplasia, when they took out their thymus and looked at it. So hyperplasia means overgrowth of that thymus tissue. The majority of thymuses showed hyperplasia, which we just talked about earlier, saying that women that are younger tend to show hyperplasia. And then different medications, they were on pyridostigmine, steroids, different ones, so a variety of them. And then this just shows what countries they're from. Sweden, the majority of them, and how many kids they'd had. And this study, again, it was nice because it's so long. They looked at the registry from 1987 to 2019. So pretty awesome length of time. So in this study, the rate of hospital admissions with MG as the primary diagnosis did not differ between pregnancy and the year prior. The risk of prolonged hospitalizations did not increase in pregnancy. So what we did see is that the admission rates were not significantly higher in the first year postpartum, but the duration, so how long they were in the hospital, was definitely higher in that postpartum year. So when we talk about postpartum period, generally we mean 3 months after the baby is born. So that's the general. And when they looked at just kind of that postpartum period, that risk of prolonged hospitalization was higher. So how we look at a study is always really important. I always, when I treat a lot of stroke too in the hospital. And so when I tell people, the clot busting drug, there's a 6% chance that it could cause bleeding. Well, if you flip that around, that means 94% chance that it won't cause bleeding. So how we say something makes a really big difference when we're taking that in. And that's a very human thing. It's common. We tend to always think bad. Okay, 6% chance of bleeding, and we don't. I like to flip it around and say, it's actually a 94% chance that you won't bleed. So similar, I feel like a lot of these studies, we kind of need to flip them and say 90% of those women did not have any MG related hospital admissions in the first year postpartum. So most of those women had a healthy pregnancy, had a healthy labor, delivery, and everything was fine. In 16 of those women in this study, it's about 10-11%. They did require at least one hospital admission for myasthenia gravis. So this subset of women is important. It's not that we don't think it's important. It definitely is, because they did experience exacerbations in the first year after birth with a higher risk of staying in the hospital longer. So, if you were thinking about having a baby and thinking about your myasthenia, I mean, this is not a bad statistic. Definitely something to consider with this, percentage of possibly doing worse, and planning for that, talking to your OB and having close relationship with your neurologist is very important. So even among those 16 women who had postpartum admissions, 9 of them, so over half of them, had at least one other pregnancy after an MG diagnosis that did not require hospitalization. So I thought that was really interesting, that it doesn't necessarily, mean that because you had one pregnancy where you ended up having to be hospitalized for some MG related thing, that the next pregnancy will be the same. I mean, I was looking at all of these studies. It seems like in the literature, it's pretty common that it's the first baby, and then subsequent pregnancies do not necessarily have the same risk. So, again, so fascinating and interesting, but we need more information. It was notable that a lot of the women had changes in their medications around pregnancy, so either before or during, and most of these were reductions or eliminations of whatever they were on, which means that they were probably pretty stable during their pregnancy. And then the flip side of that is that many of them actually started treatment or increased their treatment postpartum. So consistent with this, trend that we tend to see of worsening after pregnancy. This is what they call spaghetti plots. So just kind of interesting. In this study, they showed different ways of the number of hospital nights per year per woman with myasthenia gravis. And it's very interesting looking at before pregnancy, during pregnancy, and after pregnancy. Really pretty stable. You got some outliers there always. There's going to be outliers. But you definitely see this postpartum increase in those spaghetti plots. So that was the recent study, the May 2026, and that was the Swedish study. There's another study that is older, 2016, and this one is in Norway and the Netherlands. Also a lot of women, 246. So in this one, this population-based case control study looked at 246 women. And it was interesting because pregnancy preceded the onset of myasthenia gravis in 15% of cases, meaning they were pregnant, didn't have myasthenia gravis, and then developed it. So it kind of gives a little sense of the risk. Still low, but it's definitely there. So the postpartum period, again, they saw that it was a significant increased risk for the onset of symptoms. So in their relative risk assessment here, they looked at pre-pregnancy, how likely it was to have a myasthenia gravis exacerbation or symptoms. It's interesting. It slightly goes down during pregnancy, as we talked about, some protection from the alpha fetoprotein and other things. And then postpartum, your risk goes up again. So postpartum here was meant to be 0 to 6 months, and then it goes back down again post pregnancy. Interesting that it kind of remains a little bit more elevated um, for a while after that. When we look at the baby and the actual neonatal outcomes in patients with myasthenia gravis, we have a study from last year, which is good to have a little bit more recent information. But most women with myasthenia gravis, again, had uncomplicated, non-operative vaginal deliveries. So almost 80% of them. Again, something that we can tell our patients again with caveats. This is how it was in this particular study in Sweden and Netherlands may not necessarily apply to you, but this is this is what it showed here. Complications that they saw here, which are complications that we see in other studies that they have shown, increased risk of elective C-section. Your labor may have to be induced. Epidural spinal anesthesia may have to be used. May have to have an episiotomy where they have to sew a tear. You may have your water may break earlier, so premature pre-labor rupture of the membranes, we call that. Lower birth weight was seen in women's in the babies, and then prolonged hospitalization of the mother. So the other thing when we talk about pregnancy outcomes is the increased risk of transient neonatal MG, myasthenia gravis, TNMG. And depending on what study you look at, the risk of this is 6 to 20% of babies born to moms with AMG. That study that we just looked at from Norway, they said was only 4%. But then they noted that 40% of the infants had symptoms that when they look back, maybe they did qualify for transient neonatal MG, and some required neonatal unit care. So even though this 4% is low and maybe even lower than than some of the other studies show, this higher 40% shows that maybe they had a little bit more problems than was recognized in that. So the symptoms of transient neonatal myasthenia gravis includes weakness, which we call hypotonia. They may not be able to, breastfeed as well or bottle feed as well. May have some respiratory distress 1 to 3 days after birth. And the good news is the flip side again of that is that the symptoms tend to disappear once that baby is able to clear the mother's antibodies after birth. So those are just it's called transient because it means just for a while the baby has gotten some of the mom's antibodies, the acetylcholine receptor antibodies, and it's affecting them the same way it affects mom. But theirs is only transient. It's not ongoing myasthenia gravis. It's just until they clear that out. Another thing related to pregnancy and outcomes is sometimes infants can be born with arthrogryposis multiplex congenita. It's a rare condition that causes joint contractures and affects joints, and that's because the baby was not moving as well in the uterus or just had reduced fetal movements, and so they do have to deal with that during infancy and throughout. Usually that's treated with physical therapy and braces, things like that. We always recommend that babies who are born to mothers with myasthenia gravis be observed for 3 days, regardless of how well controlled mom is. Again, that's because of the myasthenia gravis antibodies that they may have. Not going to spend a lot of time on this, but this just kind of lists the things that are safe and not safe in pregnancy. The pyridostigmine or mestinon is going to be very safe. If we have to use something, prednisone. Some of these other ones, I guess we're saying they're relatively safe. The ones we don't want to be on is mycophenolate, so Celsat, methotrexate, cyclophosphamide, or rituximab. And we do not have information really on these newer biologics that we have everyone on now. And that's just because the FDA has not approved them for use during pregnancy. There's a lot of registries right now. All the drugs have registries so that if you get pregnant during it, you can register in it and provide information for us. So that's all I'm going to say about that. So other issues, the lack of good quality studies and the support for research in this area and women's health overall limits what we can or cannot be sure of. I kind of already talked about that. We're going to switch gears and talk a little bit about urinary dysfunction. I know Allison had talked to me about this. Some of you were interested in this, and I'm happy to kind of review this article and tell you kind of my thoughts on it. And I'd love to know your thoughts. But this was an article that was published in January in Neurological Sciences, and it was looking at myasthenia gravis and if there was urinary dysfunction in patients with myasthenia gravis. So urination is actually a very interesting, less interesting for a neurologist, more interesting for a urologist. But it's not that it's not interesting. It's very complex, though, because it involves systems that are voluntary and involuntary muscle. It involves brain signals, spinal cord signals, so many. It's very complicated. Having had to learn that in great detail in medical school brings back a little PTSD, but it's very complicated, but also very interesting. And we really we haven't looked at this a whole lot in myasthenia gravis, and I'll kind of tell you what the thinking was behind that. A lot of them were case reports, small studies. And then in women, it's a hard thing to look at because there's so many things that are going to affect urinary dysfunction. Pregnancy, delivery, weight, and aging. So how do we say this is urinary dysfunction from MG versus all the other things that can affect urination? So anatomy of the female bladder here. So bear with me, I'm not a urologist, but we do know that here, so I'll give you a little bit of know where you're at here. This is your bladder. These are the ureters, which are the little tubes that bring down the urine into the bladder from the kidneys, which are up here. So all that gets sent into this little sac here called our uterus. We have the main part of the muscle, which is called the detrusor muscle. And I'll go here, it's in this corner, but the detrusor muscle is actually made of smooth muscle, as is the internal urethral sphincter, which let's go back here, would be here on each side. And so the sphincter is always kind of a little closing muscle mechanism that prevents either, urine or gastric contents, stuff in your stomach. You've got sphincters in a lot of places in your body. And so in the bladder, smooth muscle is what the main portion of the bladder is. And then this little internal urethral sphincter, which prevents leakage, is smooth muscle as well. And then we've got the external urethral sphincter. So there's double protection for that urine not to come out. This is skeletal muscle. So when we're talking about myasthenia gravis, that's important because myasthenia gravis affects skeletal muscle. It does not affect smooth muscle. It affects skeletal muscle. Smooth muscle is not under voluntary control. So you can't make your smooth muscles, like just thinking about it, make them do what you want, just as much as you can. Like if your hand is moving or your leg, you control that. In myasthenia gravis, we know that it's skeletal muscle that's affected. So when we're looking at the bladder back here again, This is not generally going to be affected in myasthenia. The internal urethral sphincter won't. But actually, this external urethral sphincter may be affected, right? So this external urethral sphincter is under voluntary control that contracts to prevent urine from leaking, but also relaxes when you're going to go pee. So it's really interesting, right? It's contracting, it's preventing the urine from coming out, but then when you need to go, you relax it and then you're able to go to the bathroom. And that's why uh potty training is a whole thing. You've got to train. We were talking about how complicated it is. You're training the brain, you're training the bladder. It's a very complicated mess. So according to this paper, the external urethral sphincter could potentially be involved in myasthenia gravis because of weakness and fatigability. So it's certainly possible. So this study looked at 86 patients with myasthenia gravis and 90 patients who were controls. So I liked that they included control patients. We talked about randomizing. You have to not just look at patients with a disease or with a medication. You have to look at a normal population. So these were 86 patients, 56% of them were men. So this doesn't look just at women, this looked at men and women. So all the participants in this study did several questionnaires. They did a questionnaire that looked at, it's called the International Consultation on Incontinence Questionnaire. They did that form, and then they did an overactive bladder symptom score. And then, of course, they did the MGADL, so the Myasthenia Gravis Activities of Daily Living, which is one of our most common skills in measuring the severity of your myasthenia. So in this study, the patients had significantly higher prevalence of urinary incontinence symptoms, 52% versus 12% in controls. So definitely a difference there. Obviously, the patients that are older, they saw a higher incidence of urinary incontinence, UI, urinary incontinence. So 63%. And then younger patients had less of this, which makes sense, right? The older population in general is going to have more urinary incontinence than a younger population. And they saw that overactive bladder, so urinary frequency, having to go all the time, not fully emptying, were more prominent in patients with MG. Again, remember 86 patients, so not a huge study, but it was nice that they were able to do a control group. In this study, it was interesting that the MGADL score, so measuring how bad someone's MGADL was, actually predicted whether they were going to have urinary incontinence. So and it makes sense, right? If your MG is worse, all your muscles that are skeletal, presumably, it will have more dysfunction. So since we're talking about women, among women, I picked that out. The likelihood was higher than in men with MG, with 63% of women who had myasthenia gravis versus 10% of those same female controls reported this. So definitely higher in women. And again, the issue here is that it's hard to control for all the things, but there was certainly a difference that was seen here. So several things that I saw missing from this study. No urodynamic studies. So when we're looking at urinary studies, it's nice to have, we're looking at urinary incontinence and those types of urinary or overactive bladder. You want to have actual urodynamic studies, not just reliance on questionnaires. It's hard to just rely on questions. We actually want to see science of looking at the urine, how it flows, and we call them urodynamic studies. So that would be really nice to have included in this. I think it's a nice study. It's a great start, but there's a lot missing to it. They also did not put any dosing or the timing of the periodostigmine, which I think would have been helpful. And they don't include any data on BMI, which we know those things affect urinary incontinence. So I don't think it's a bad study. But I did see some things in there that left me with a lot of questions. I was a little annoyed at one of the things it said at the end. This is just me needing to get this off my chest mostly. But they talked about how oxybutynin, which and some of the other medications that are used for urinary incontinence, shouldn't be used in patients with myasthenia gravis. And I do not agree with that, because the problem is that oxybutynin, and we're looking at here neurotransmitters, acetylcholine, and then acetylcholine receptors. There's two types of acetylcholine receptors. There's the nicotinic and muscarinic, is what we call them, nicotinic and muscarinic acetylcholine receptors, and they sit here on this cell membrane. The ones involved in myasthenia are the muscarinic receptors. And sorry, in in myasthenia are the muscarinic receptors. The nicotinic receptors are a different class. And so when we're talking about the medications for urinary incontinence, oxybutynin targets an entirely different set of receptors than they would for myasthenia. So I'm actually going to write to the to the authors, because I was, I just don't agree with that we can't use those. In fact, that's one of my main questions that I get from urologists. Can I use this? Because I know it's an anticholinergic, and that's my recommendation for them. I say it targets different receptors. You're not targeting the same receptors that are involved in myasthenia. They're a totally different class of receptors. And so I just would hate for patients to not be able to get, some relief that they would need. Because obviously, I think the point of this study was get your MG, or get your MG under better control, which I think is obviously what you want, what we want as physicians, as the treatment for this. Acknowledging that it may be part of it. But also, I think that, yes, we're going to use all the medications that we have available to us, but I always hate for people not to get something that they could. So that's my spiel on that study. So I'm interested to know what you guys think. But I hope you guys are watching the US. We're doing pretty good in the World Cup. And I have to put in Argentina, because who doesn't root for Argentina? It's kind of like rooting for the Chiefs. You have to root for them, for me at least. So I am happy to take any questions.
Dr. Papsdorf, that was really informative. Thank you so much. It looks
You're
like
welcome.
we have a couple of questions in the Q&A. Do you want me to
Yeah.
read them, or do you want to read them and go from
Yeah,
there?
I can read them. So the first one do you want me to say the name or no?
No, you can leave the name out. Yeah.
Okay. Says I had a complete hysterectomy at 35 and opted to not take estrogen afterwards. I had a DVT in my 20s and was afraid of having more if I took estrogen. I was diagnosed with myasthenia gravis at 64. Do you think that my having no estrogen for all those years may have caused the MG? I don't, yeah, like Allison said, specific questions, it's hard for, because each person is different. Now, I would think that that would be protective, in fact, because you didn't have the high estrogen, which is what we think causes the increase of younger women getting and when I say younger, I mean up to, depending on the study, up to 50, meaning younger. So we see the higher risk in younger women. So I would say it would have probably been protective, because if you weren't diagnosed with MG until later, I don't think that would have necessarily triggered the estrogen. Of course, having low estrogen for that long is going to cause its whole set of issues. But with relation to MG, I don't know that I can, definitively say that, but I don't think it would have necessarily caused the MG. And then the next one says, I went through 2 pregnancies. Whoop, hold on. and my MG symptoms subsided in the second half of pregnancy. So yeah, that's, kind of consistent with the fact that we know that that alpha fetoprotein, that protective protein that I think is so cool, like why aren't we harnessing that into a treatment? It makes you, get better during many women get better during the second half of pregnancy. Of course, that drop then is how we see the postpartum worsening. It seems many of the MG studies on women were done in Scandinavia. Is that region known for studying men versus women? So, like I said, it's not necessarily that they're known for that, maybe a little bit more. It's more of their healthcare system allows that to be easier because they have national healthcare systems, so they are able to kind of pull from that much easier than we are here. We don't have a nationalized healthcare system really, so it would be hard to go pull them. I mean, it's hard enough getting medical records from one hospital to the other. Imagine, like trying to do a population study like this is very hard. So yeah. Will using replacement hormone after menopause increase the likelihood of developing MG? I did not see any, not that they're not out there. I didn't really look into this when I was looking through, that's a great question actually. Through all these studies, I think it's definitely something to look to look into as we are learning more about hormone replacement therapy and we're getting a little more comfortable in general as a medical community giving women hormone replacement therapy. I think it's absolutely necessary. It's far overdue for us to do it. We also don't have the studies even in that population. Forget about MG. Hormone replacement therapy, it's this whole monster of the lack of studies, and there's danger in that. I feel like, we need more studies because we need to be our primary cares need to be able to tell us what to do. And I'm so passionate about this as I'm getting closer to that part of my life, that I think it's really important, but I don't know that I have a good answer for you. I don't think it would increase your risk of myasthenia, but again, I don't know that. Potentially, you could say it would, because again, we know estrogen does cause an increase of your immune system autoreactivity. Are there any studies about the impact of postmenopausal? Okay, it's kind of the same question. Someone else was asking that. So I clearly need to look that up a little more, and I can definitely get back to you. I think that's a great question. How much I'm going to find on that, I'm guessing is going to be very little, but it would be, I'd love to look it up for you guys. And let's see, have you seen any improvements of MG symptoms in patients with the use of GLP-1? Me personally, I don't know that that is necessarily true. For me. So I think that there's a lot of it's so new. The GLP-1s are new that we haven't really begun to look at those for MG, but I think it's definitely going to be something that is going to be looked at because we're looking at muscle loss, right? Supposedly muscle loss and how that affects MG. Great study question. And then is there any let's see, is there any information on women who are postpartum for about 2 years and who stopped breastfeeding so menstruation is starting again to stop flares? Yeah, this is really interesting. There wasn't a lot of information. I did see that overall breastfeeding seems to be protective. In the majority of women, they tend to stay stable. And yes, after they stop breastfeeding, and a couple of the studies I looked at, small studies, they can worsen. Then there were some that said because your levels of estrogen drop when you're breastfeeding, which didn't make a lot of sense to me. But you have so many hormonal changes during breastfeeding, people can worsen. So that's not a great answer to your question because it basically shows that we don't know enough. But I would definitely say that the breastfeeding in general, and just talking about breastfeeding medicine in general, is protective for you and for baby a lot of times. So definitely worth more looking into. Those were great. I love those. Any other questions?
I don't see any others. Again, Dr. Papsdorf, thank you for taking the time out of your evening to speak with us and educate us. Really
Yes,
informative.
I love doing this, and I love the questions too, because it makes me need to delve a little further. And like I said, I was so surprised about the lack of information in this particular little
Yeah,
space, because we have so much MG studies and information now, but we don't have great studies, great information on this. But I think that it's not that we don't have any, but it's definitely a lot of questions, a lot more to look into, and it's kind of made me want to, do something with it. So
thank you so much again for being here with us tonight and your passion. You have a huge passion for our community and we really
I,
appreciate it. So
I
this will
appreciate it.
conclude our monthly webinar and we hope to see you next month. So thanks everybody. Good night.
Good night.